We'll continue our talk today. Our next speaker is Dr. Choueka, who is a attending physician in the Department of Neurology and Director of Headache Medicine at Maimonides Medical Center. He's an assistant professor in the Department of Neurology at SUNY Downstate Health Science University. Murray is a homegrown, excellent physician, neurologist, and he went to Penn State Hershey for his medical degree and completed residency in neurology at SUNY Downstate. And then he was the chief resident last year during his training before he went to Mount Sinai for his fellowship training. And then we couldn't wait to recruit him back. And after day one, he quickly became one of the busiest neurologists in the department because of the demand for people to see him. So people had to pay bribes to get into his schedule. Dr. Choueka is going to talk to us today for about the stroke in migraineurs, the link in between. Please join me to welcome Dr. Choueka.
Wonderful introduction. Stroke and migraine, is there a link between? Let's try that again. We're going to talk about whether there's a link between stroke and migraine and what that link is. We're going to focus a little more on epidemiology and then some clinical aspects of it, some clinical applications of this. First question, there was a study in 2017 that found an odds ratio of 6.1 for ischemic stroke in patients with migraine with aura who took estrogen-containing birth control. What was the reference group? I'm not going to answer this now. Well, actually, if you just think about what the answer is, we're going to get to it a little bit later. But I think this is a really important question when we think about this. Second question, which of the following arteries do triptans constrict? MCA, supraclinoid ICA, the extracranial ICA, all of them, none of them? So why is this whole question important about the link between stroke and migraine? So estrogen-containing OCPs are supposedly contraindicated in migraine with aura, according to ACOG. However, for a lot of patients, using other methods may not be a great option. We all know that migraine aura can sometimes mimic stroke, and we see a lot of the stroke specialists here see a lot of those patients in the emergency room, including my patients. There's this supposed migrainous infarction diagnosis, which I put in quotation marks for a reason. And then triptans are also supposedly contraindicated by the FDA if a patient has had a prior ischemic stroke. There are two ways we can approach the question of this link. You could look at the prevalence of migraine in patients with stroke, but when you do so, you're selecting for an older population. They have a lot of cardiovascular risk factors that are more dominant than migraine, if there is a link. They may have cervicogenic headaches, not the necessarily genetic migraine that we're really thinking about. And how's a history of migraine addressed in those patients? If someone has a stroke at the age of 70 and they had migraine at a younger age, but they no longer have it, very difficult to really look at data in this population. The other thing you could do is look at the prevalence of stroke in patients with migraine. But when you do so, you have a much younger, healthier population, and where the absolute risk of stroke is generally less, and it's a less clinically meaningful group of, it's important, but it's less clinically meaningful than answering this question for the older population. And you need a ton of data to answer this. So for the prevalence of migraine in patients with stroke, there's not a lot of high quality evidence to answer this for older patients. But for younger patients, there's some high quality evidence. In 2020, the Secreto study, this was looking at cryptogenic ischemic stroke, and it was a prospective case control study, patients ages 18 to 49. And what they found was that if you have migraine with aura, even after adjusting for cardiovascular risk factors, the odds ratio for ischemic stroke was 3.5. But if you look at migraine without aura, you do not see, the odds ratio is 0.6, it crosses 1. There wasn't really an increased risk of stroke in this population. They did control for PFO status because that would be a major confounder. And for the patients there where PFO was assessed for, they found that whether it was absent or present, the odds ratio unadjusted for cardiovascular risk factors was about 5. And they also found that the migraine aura prevalence was 3 times greater in those with PFO than without a PFO. A lot of studies have been done on the nurses' health study cohort. This was looking at nurses ages 35 to 57. And they found that the adjusted risk hazard ratio for ischemic stroke was 1.62. They didn't provide the absolute risk of stroke. And we know that the absolute risk of stroke in this age group, it's a little bit of an older age group, but it's still relatively low. And we really don't know about migraine without aura versus migraine with aura. So a meta-analysis was done. Can't see, I'll just move this over so you can actually see it. Looking at migraine and the risk of stroke. And they looked at all the prospective cohort studies that were done up until that point. And they looked at 2.2 million patients with migraine. About 3,300 of them had a stroke. And compared to patients without migraine, those with migraine had a relative risk of ischemic stroke of 1.5, but there was not an increased risk of hemorrhagic stroke. Again, they didn't really look at migraine with aura versus migraine without aura. Frozen. There we go. In 2023, a study was published that actually did look at the absolute risk. And what's interesting about this one is this was in a Danish population. They looked at men versus women. And the absolute risk difference for ischemic stroke for migraine versus no migraine was 0.5% increase for men and 0.3 increase for women. And if you look at the absolute risks, they're fairly low. So for men, 1.9 versus 2.3 if they have migraine, and for women, 1.2 versus 1.5. So looking at this, we can't explain everything with estrogen. We're not talking too much about the pathophysiology behind this link, but actually whether there is a link. But it's clearly not all estrogen because there is increased risk for men as well. The hazard ratio was 1.2 for men and 1.2 for women. In the Framingham cohort, they found something very interesting. Having a history of migraine, and this is the blue one, shows if you have a history of migraine, there's an increased risk of having a high Framingham score. So perhaps the history of migraine, there's something genetic that puts these patients at risk for having cardiovascular risk factors. But in the 5 years they looked at this cohort, if they had migraine at baseline, that means just migraine when the cohort started, and these are patients ages 45 plus, or they have incident migraine during those 5 years, they did not have an increased risk of having a high Framingham score. So this goes back to our other question of how do you deal with migraine that starts later in life? Are those patients at more risk? And it seems to be that from this, if they have a history of migraine, they may have more cardiovascular risk factors later in life. There's not a lot of other data to look at this question specifically. This is really all I could find. Very big question. Does migraine aura increase the risk of stroke? There was a meta-analysis done in 2017, and they looked at all these cohort studies, and they tried to separate out migraine with aura versus migraine without aura. And for migraine without aura, that's the second red box here, they found that there was not an increased hazard ratio for ischemic stroke. It was about 1.1. But for migraine with aura, the hazard ratio for ischemic stroke was 1.56. From this, we really learned it's probably migraine with aura that's driving this data. And all these previous studies that just looked at migraine in general, they may have been missing that little part. This is probably the most clinically important question regarding the link between stroke and migraine. So according to ACOG, estrogen-containing OCPs are contraindicated in patients with aura, and this has been their recommendation for a long time. However, combined OCPs are more reliable than progesterone-only pills in terms of preventing pregnancy. Also, combined OCPs are used to treat PCOS, hirsutism, dysmenorrhea. There are various reasons why a patient may want to have an estrogen-containing birth control pill. I often see patients who are already on an estrogen-containing birth control pill, and then I diagnose them with migraine with aura. Or I get consults sometimes, patient is on an OCP with estrogen, they're diagnosed with migraine, and I get the question, can they be on the estrogen? These patients very often do not want to switch their birth control methods. It's not something that patients like to do if they're happy with what they're on. This study did not look at migraine, but it's an important study. It was published in New England Journal of Medicine in 2012, another Danish cohort. And they looked at the thrombotic stroke risk with varying estrogen doses and varying progesterone compounds, which I think gets missed. People don't realize that there's that variable. With increasing estrogen dose, there was an increased relative risk of thrombotic stroke. Not a big increase, but there does seem to be a small increase with increasing dose. There are previous studies to this that showed that patients on more than 50 micrograms of estrogen per day did have an increased risk of stroke compared to less than 50. But this one further subdivided it out for the lower estrogen doses. Today, there are a lot of patients taking 10 micrograms, which is not included in this. When they separate it out by progesterone compound, there are a couple interesting things to look at. For I cannot pronounce some of these, but for desogestrel, there was a pretty high adjusted relative risk if they were on estrogen of 30 to 40 micrograms. Whereas for drospirenone, which is much more commonly used today in the United States at least, the relative risk was a little bit lower. And if you look at the 20 microgram group, that's at the bottom, and if they use drospirenone as the progesterone compound, there was not an increased relative risk. And that's very important because this is one of the main study that gets cited to say that estrogen increases the risk of stroke. Systematic review in 2017 looked at estrogen-containing contraception specifically in women with migraine. Overall, the quality of evidence in most of these 15 studies that they reviewed was low. None of them assessed the risk of stroke in patients with migraine by a function of estrogen dose. And only one of them actually assessed aura versus no aura. And we're going to look at that study a little more. They did not define the frequency of aura for these patients. Did they have 1 or 2 auras in their life? Are they getting 1 per week? We don't know. But what they did find was an odds ratio of 6.1 for ischemic stroke for patients with aura and 1.8 for patients without aura. Dr. Sheikh, thank you for referencing my study. Again, we're a little blocked here. Let me move this. Can't move it. So, use of combined hormonal contraception with migraine and risk of ischemic stroke. So, this was a case control study. Young woman, age 15 to 49, with first ever stroke. About 25,000 patients had a stroke. It was the only study to assess ischemic stroke risk with estrogen in migraine with aura. If you look at migraine with aura with estrogen, the odds ratio for ischemic stroke was 6.1. But the reference group is very important. The reference group was no migraine, no estrogen use. When you see a patient that has migraine with aura and you're trying to answer the question of whether taking an estrogen-containing birth control pill will increase their risk of stroke, that patient's reference group is the second one here, migraine with aura without estrogen use. They can't modify having migraine with aura. For migraine with aura without estrogen, the odds ratio for ischemic stroke was 2.7, so it was increased, but that's not modifiable for a patient with migraine with aura. The number of cases was very small. So remember, when you're looking at a systematic review and they say the odds ratio is 6.1, well, they're referencing only one study, and that one study had actually very few cases of stroke in these patients. Additionally, for migraine without aura, if they took estrogen or did not take estrogen-containing birth control pills, the odds ratio for ischemic stroke was 2. But we have systematic reviews that show that probably that's not the case. If you look at all the cohorts that have been done on ischemic stroke and migraine without aura, there does not appear to be an increased risk of stroke. So was there some confounder in this data that led to an increased risk of stroke in general here? So that odds ratio of 6.1, maybe not so real. If you want to just reference it to the second group here, migraine with aura without estrogen, maybe that odds ratio is actually about 2, and the 95% confidence intervals are going to be, very, very wide. There's really not a lot of data here to answer this question. So my recommendations on combined OCPs. If a woman has migraine without aura, it's okay to use it. I wouldn't restrict it at all. The data seems to suggest there isn't really a link between estrogen and increased risk of stroke. If they have aura, I would discuss the following points with the patient and let the patient decide. Make sure they understand there's low quality evidence that there may be a little bit of an increased risk of stroke. That if they've heard about this odds ratio of 6, if they Google it, this is generally what you're going to find. Make sure they understand that's in comparison to patients who do not have migraine and do not have aura and do not take estrogen-containing birth control pills. That is not the right reference group. The absolute risk of ischemic stroke in a young population, if they don't have other cardiovascular risk factors, is really small. And ask, will a non-estrogen contraception method achieve the same goal for the patient? I would say more than half of the patients that I talk to about this, if they're already on an estrogen-containing birth control pill, they usually choose to stay on it and just use a low-dose estrogen. So our next topic, migrainous infarction. So the International Classification of Headache Disorders defines this as an infarction that occurs in a relevant area to a migraine aura, but the patient already has to have migraine with aura, and the aura has to be typical of previous attacks, except that the aura lasts more than 60 minutes. It's based on a collection of case series and reports. It trends towards younger patients, tends to be in the posterior circulation, which is interesting. And infarctions overlapping vascular territories is rarely seen in these patients. And we know that cortical spreading depression crosses vascular territories. This is one of the case series on the topic. There are others, but I'm going to pick on this one, and some of the others have similar problems with them. In this one, 70% of them were posterior circulation, and 11 out of 18 where they assessed for PFO had a PFO. So that's an important confounder. 8 patients had MR perfusion. None of them had hyperperfusion overlapping vascular territories. And migraine there are vascular changes that occur, but they're secondary to neuronal changes, and migraine's a neuronal disorder. And the vascular changes should cross vascular territories. 6 out of the 18 patients in this series did not have a history of migraine with aura. So that, it doesn't really follow so much the International Classification of Headache Disorders, and you'll see in the other case reports, case series, that's very similar as well. It's very difficult to determine a direction of causality. Is the ischemic stroke causing the migraine aura, and that's what you're clinically seeing, or is migraine aura somehow in these cases causing ischemic stroke? There's not enough data to really answer this question. If it is the second one and this exists, it's very rare. Posterior circulation tendency, reporting bias. If someone has a prolonged motor or sensory aura, you almost never think it's an aura until the MRI is negative. And I think that can lead to less of these cases being seen in case reports, case series, because you're not thinking about migraine, you're not writing that in the chart when you first see the patient. So assess for other causes of stroke really, really carefully, and consider the huge number of patients that have a prolonged aura and the MRIs are normal. This is one of my favorite topics, triptans in general, so I always bring it into my talk somehow. Triptans in patients with cardiovascular risk. The FDA on the label says all these are contraindications, and most of them are complete nonsense. They're based on case reports, very poor evidence. They've been on the FDA label since 1991 when sumatriptan was first FDA approved, and it hasn't changed. Specifically, we're going to look at stroke, but we're going to talk about ischemic coronary artery disease because that's just to demonstrate that these labels don't get updated. In 2023, there was a survey of American Headache Society members, and they asked them, do you give triptans in all these populations, all these supposed contraindications? For history of stroke or TIA, more than half of American Headache Society members said at some point they do give triptans to these patients. For hemiplegic migraine, which was previously thought to be a vascular disorder, and now we know to be a neuronal disorder, 70% give triptans at some point. And for prolonged aura, almost all gave triptans. So there are theoretical concerns for cardiovascular risk because triptans are serotonin or HD1B and D agonists, which cause vasoconstriction. Yeah, these receptors are present on coronary arteries, but the ones on coronary arteries are mostly not 1B and D, whereas cerebral vessels do have these receptors. In 2004, so this is a long time ago, but the dogma still persists that there's this big contraindication in coronary artery disease. They looked at patients with normal coronary arteries, gave them IV elatriptan at huge doses or sumatriptan subcutaneous, and there were no EKG changes in these patients. There was no difference in artery diameter over time compared to placebo. So triptans do not constrict coronary arteries. There's no evidence that triptans cause stroke, yet still on the FDA label. Very similar study was done for the cerebral arteries. So in Lancet 2013, they did MRAs in patients with migraine at the time of the migraine. They repeated the MRA 30 minutes after giving sumatriptan subcutaneous. And here's what they found. For the MCA, there was no, and they looked at the pain side and non-pain side. There wasn't too much of a difference. But for the MCA and the cerebral ICA, there was no change, basically no change in diameter of the blood vessel. But for the cavernous ICA, cervical ICA, and all these other blood vessels, there was about a 10 to 20% decrease in the vessel diameter based on the vessel. So perhaps for patients with MCA stenosis, for supraclinoid ICA stenosis, there's no good reason why you can't give these patients triptans. It doesn't constrict those blood vessels. And for small vessel disease strokes, it's probably fine. There was an abstract published or abstract presented at the AHS Scottsdale Symposium, and they looked at patients receiving acute migraine treatment. They looked at non-fatal MI, non-fatal stroke, all-cause mortality. They looked at triptans, opiates, barbiturates, and NSAIDs. At baseline, very few of the patients had cardiovascular risk, but of the patients, of the 1 to 3% that did, they looked at their event rate at 60 days. And for the lowest was for triptans. They had the lowest risk of stroke, MI, or all-cause mortality. It was higher for opiates, barbiturates, and NSAIDs. And based on this, a lot of neurologists now think that triptans are probably safer for these patients than NSAIDs, opiates, or barbiturates if they have cardiovascular risk factors. basilar and hemiplegic migraine. Basilar is no longer the term used. It's now just migraine with aura or migraine with brainstem aura. Basilar migraine is on the FDA contraindication list, but migraine with brainstem aura didn't exist at the time, so it's technically not contraindicated. The vascular theory of migraine is, at this point, debunked. There are vascular changes, but it's not the cause of the migraine. But based on that theory, this group of patients was excluded from triptan trials, and they were put on the contraindication list. Cortical spreading depression is no longer just a theory, because very recently there was a case report of a patient with intracranial EEG monitoring where they actually showed cortical spreading depression in a human for the first time during a migraine aura. Very important to note that cortical spreading depression crosses vascular territories. There are a few case studies or case series on this topic of hemiplegic migraine, basilar migraine. There were no complications in any of these patients who received triptans. So triptans are not contraindicated in migraine with brainstem aura. Go ahead and give it. Triptans are also not contraindicated in hemiplegic migraine. Take-home points. Migraine with aura is not a risk factor for stroke, as far as we know right now, based on the data. Migraine with aura does seem to be a risk factor for stroke. If there is some confounder, we don't know what it is yet. The absolute risk increase for ischemic stroke in patients who take low-dose estrogen, that's 10 micrograms, 20 micrograms, is very small if it even exists. Triptans are likely safe to use if a patient has a prior ischemic stroke due to small vessel disease, but not due to cavernous or extracranial ICA stenosis, because triptans do constrict those blood vessels. You can use triptans in hemiplegic migraine and migraine with brainstem aura. And this last part is migrainous infarction may not be a real thing. I don't think it's been definitively proven at this point. So that's up in the air. Thank you.
Any questions for Dr. Choueka? Migraine stroke, yes.
I have two questions. Great talk. One is I'm constantly confused as to whether people with migraine with brainstem aura have a particularly increased risk for stroke relative to other people with migraine with aura. Is there any differentiation there? And my other question is, back when I was in med school, we were always taught that migraine angiopathy or migraine angiitis or migrainous vasospasm was on the same spectrum as RCVS. But now that this concept of migrainous vasospasm has sort of been disproved, do we still think of RCVS as a headache disorder or as something that people with migraines are at higher risk for?
Right, so the first question, migraine with brainstem aura versus migraine with aura in general, we barely have enough data to suggest that there's increased risk of ischemic stroke and migraine with aura in general. It would be nearly impossible, and I'd imagine it's only a few cases in that case series where they looked at it, or in that cohort where they looked at it, where they had migraine with brainstem aura. So it's an impossible question to answer. As for the second question, RCVS and the vascular changes that occur with migraine, RCVS, the clinical presentation is very different than migraine. These are thunderclap onset headaches. I think they are separate disorders entirely. And in those cases, the patients are having migraine secondary to the RCVS, actually. And there is obviously a clinical distinction. Sometimes you have patients where it's actually unclear what's going on. But I believe they're separate disorders.
Thank you.
Any other questions? Lydia's first.
Thank you so much. So then the question based on your talk, should we kind of stratify certain patients, potentially get carotid Dopplers before putting on triptans? Or do we even need to do EKGs before triptans anymore? And the second or third question is oftentimes you get a brain MRI on patient for different reasons, and the radiologist quotes changes likely consistent with migraine or Lyme disease goes to any particular recommendations if you do see the changes on the imaging in terms of management? Thank you.
So the latter question first, these migrainous changes or these non-specific changes, that's a whole nother talk even. But there's no evidence right now to suggest that there's any intervention that should be done based on that, or that you should change management based on seeing those white matter spots. The first question that you had was, what was the first question? Just remember. Dopplers. Did you screen patients? Do you do EKGs? Do you do carotid Dopplers before giving triptans? I usually don't unless there's a reason to think that they have carotid stenosis, but if they have, if I see incidentally on an MRI, it's a small vessel disease stroke, and I think it actually might be from carotid stenosis, then I'll go ahead and screen them. EKGs I don't do. If they have risk factors for coronary artery disease and they would meet qualifications for needing a stress test, usually I will go ahead and do that first, because in severe coronary artery disease, we don't really have a lot of retrospective evidence to say that they're safe or that any medication is safe to give them, but that might be important to know. But I do not do screening EKGs for older patients who are taking triptans.
Excellent talk, Murray. Thank you. It's always nice to see data-driven talks with rigor, and you fulfilled that criteria. So thank you for the update. One of the questions I have is my understanding, and please correct me if I'm wrong, is about 70% of people with migraine have a family history, or you can suggest maybe there's a genetic component to their migraine. I wonder, is there any literature that you came across in preparing this talk or in your knowledge that there's a differential risk of stroke potentially with aura if you had a family history of migraine versus not?
Right. So the only data I came across was actually that Framingham cohort, where they found that patients with a history of migraine had a higher risk of having a high Framingham score. And what I thought from that is perhaps if you have genetic migraine, if it's from a family history of it, not something that developed due to some other secondary cause throughout life, that put you at a higher risk of stroke. But I did not come across any high quality data to answer that question.
Any other questions? Yes. Please step to the microphone so the audience online can hear you as well.
Would there be any benefit to a baby aspirin for or against? There were some studies that it's better with it, some studies that it's worse with it, as far as patients on oral contraceptives.
To prevent stroke, you mean?
Right, prevent strokes in those groups.
So there may be, I may not have come across it because I wasn't looking for specifically at that question, and there might be data for patients just in general on oral contraceptives. Regardless of whether they have migraine or not. In regards to migraine specifically, I did not come across any data that answered that question.
I do have a question, Murray. We can't get you off so easily. So migraine and PFO, there has always been this suspicion link, and we talk about actually with Dr. Elkin at the break with Dr. Franco. And I have seen patients who had PFO was closed by Dr. Franco successfully without atrial fibrillation complications. They come back telling me their headache's gone. And they do have these vitamin ischemic changes or dots, whatever they call the radiologists throw everything in there, kind of wastebasket type of diagnosis. What do you think of the link between there, or what kind of criteria do we think something needs to be closed with migraine with aura or on estrogen? No acute infarction, but some lesion in the brain, right? So what are the criteria in those type of cohorts you'll be considering or studies to be done for?
I don't want to answer the question too definitively because I don't think I've read all of the relevant literature on that exact question. I don't want to give a strong recommendation to the audience on this, unfortunately.
Okay, to be continued.
Yes, to be continued.
Thank you. Oh, one more question. We have a couple of minutes.
Hi, I just want to tie my question, well, piggyback off of the young man who said something earlier as far as genetic migraines, and also put point on Leah, I believe her name was beforehand, with women and migraines. So in the, well, not women and migraines, women and strokes. If it's a genetic migraine, you're also a woman, and say it comes around with menses, in that sense, is there any studies that have been done that would tie, like, say they put her on sumatriptan, but she's also taking the oral contraceptive, that might aid in both a woman's chance of getting a migraine because they're more likely versus, I'm losing my train of thought, but in that sense of things,
You mean, is there increased, is there anything to stratify the increased risk of stroke?
basically.
Yeah, so no, there really isn't enough. The only thing we could say is that maybe with migraine with aura, there's a little bit of increased risk of stroke, but for migraine without aura, there isn't really. And even if there is that's not a reason to not give a triptan, because triptans don't cause strokes.
Mm,
That's really the more important answer.
okay, thank you.
Oh, when we were talking about that back, my question made me think about women with PCOS who have to take that. And I was wondering if there's any research on or data about women with PCOS and whether they are more at risk for stroke if they're on these medications and have to be on some type of birth control because they have something like hirsutism or something like that.
Right, so that's a very important question, and why it's so important to answer the question of whether estrogen increases the risk of stroke. Today, we're using low-dose estrogen. I don't think there's high-quality evidence that low-dose estrogen, 10 micrograms, 20 micrograms, increases the risk of stroke substantially enough that it should change how you manage these patients.
Thank you.
Factor.
Thank you, Maureen.